Thank you, Ranmini. Thank you very much for this opportunity to present in this podium. Really feel privileged to be here. My presentation is a basic one. My colleagues will present their very sophisticated surgical techniques. I will describe how we are trying to tackle ROP blindness and how we are trying to save more eyes in kids with retinoblastoma. In Sri Lanka, pediatric ophthalmology started in 2008. And up to now, there are 5 established pediatric ophthalmology units. Sri Lanka is a small country with only 22 million people, 350,000 live births every year with 10% premature. So we'll go to the first topic, ROP. As we know, ROP is a potentially blinding condition in very premature babies. So worldwide, intensive screening programs and evidence-based treatment protocols have led to reduced blindness, but still a large amount of babies become blind every day. But in Sri Lanka, blindness is extremely rare. So we found blindness, we already know blindness can be due to tractional retinal detachment, and we found that blindness can occur due to overtreatment as well. So both can be eradicated by using simple diagnostic approach. So how we treat ROP in that we classify them into 9 subgroups. So accordance with BEAT ROP study, we treat zone 1 ROP with intravitreal bevacizumab. IVB is intravitreal bevacizumab. So on 1 stage 3, even without plus disease, we treat with bevacizumab. Posterior zone 2 stage 3, also there's no question about it. We treat with intravitreal bevacizumab. If the ROP stage is more anterior, particularly if there's no very prominent plus disease, we treat with laser. So zone 2 stage 2 ROP is a gray area in ophthalmology literature, whether to treat or not. So we do treat posterior zone 2 stage 2 with plus disease with intravitreal bevacizumab. But if the ROP stage is more anterior, more closer to the nasal aura, we don't treat because most of these cases resolve spontaneously. Zone 3 stage 3 is another gray area, whether to treat or not, but we do treat to prevent other consequences like vitreous hemorrhage and tractional retinal detachment. So we treat zone 3 stage 3 with laser. We don't use bevacizumab in that situation. Stage 4A, invariably you have to do laser. Sometimes you might have to ask your retinal colleague to go ahead with the encircling marker. So finally, recurrence ROP after intravitreal bevacizumab, I reclassify according to into one of these categories, previous categories, and treat accordingly. So it's a luxury if you can do the intravitreal injection in your theater with the facility of a operating microscope. But if the baby is too sick, too small to bring to the eye theater, we have to we used to go and give on the bedside. So we give the low dose, having the advantage of faster revascularization of the retina, and you are injecting a smaller volume into the tiny eye. We always inject under topical anesthesia, a restrained baby. Laser, of course, we do in the eye theater. We don't move the laser machine too much. And according to our protocols, the babies are bigger. The babies who need laser treatment are much bigger, so they can be brought to the eye theater without much problem. If the baby is tiny, then we do under topical anesthesia, but large baby, struggling baby, we do not hesitate to give general anesthesia. So we use 532 nanometer green laser, the small spot size. So you can see here, we are treating more posterior disease with intravitreal bevacizumab, and there are recurrences, but the level of myopia is very low. This is the second year refraction. So the recurrences we treat, again, the posterior recurrences with bevacizumab injection, anterior recurrences with laser. So we preserve the option of laser mainly for more anterior disease, like zone 3, stage 3, stage 4A, and zone 2, stage 3. So again, there is some degree of myopia, but it is not very high. Only in stage 4A cases where you have sometimes you might have to put encircling buckle, the myopia is high. So blindness due to retinal detachment and excessive treatment can be eliminated in ROP. So retinoblastoma, next we move to the topic of retinoblastoma. We know it's a commonest intraocular solid tumor in children. In Sri Lanka, we find 20 to 25 cases every year. Unfortunately, majority of the cases, about 90% of the cases are either group E or D on presentation. And as a result of that, our enucleation rate is very high. So why such high enucleation rate? Mainly because of late presentation. And at the end of the treatment, standard treatment, we find too much vitreous seeds, too much solid tumor left to treat with. So we have to enucleate those sites as well. So we thought of controlling those three factors to reduce the enucleation rate. So how did we get the referrals early? That's through education. Not only the general public, the professionals also. So there are a lot of myths and misconceptions about the squint and abnormal red reflex. So a lot of professionals think squint is not a bother. They tell the squint will disappear after 2 years. But they defer examination of a small baby with a squint. So how did we encounter that? Through newspaper articles, TV, television discussions, workshops, international collaborations. So a lot of work has been done to educate general public and the professionals, including pediatricians. So vitreous seeds is a major threat to the survival of the globe. And we found intravitreal chemotherapy is the appropriate way to save these globes. Presence of vitreous seeds not only scale up the diagnostic level, they also make the survival of the globe very difficult after treatment. So you can see you need more injections for certain cases, and it takes awfully long time to resolve. So we never use intravitreal chemotherapy as the first-line therapy. Rather, we use it for recurrent and resistant vitreous seeds after standard treatment. We use two drugs, melphalan and topotecan. But unfortunately, melphalan is very unstable solution. Once you dissolve it, it becomes into, it breaks down very fast. So if you rely on your oncologist to deliver melphalan to your doorstep, you're too late. You will inject only water into patient's eyes. So we thought of reconstituting the drug in our own eye theater. So we started doing it, and the results are fantastic. So now we have become pharmacists who are reconstituting the drugs as well. So to manage a solid tumor, we found this excellent laser machine, infrared laser machine, which was donated by one of my patients. And within 1 year, we found we have saved a lot of globes with this powerful laser. So over the last 4 years, we found our rate of enucleation has gone down from 75% to nearly 63%. So we are in the process of getting down it even further low by introducing intraarterial chemotherapy. So pediatric ophthalmology is a difficult field. Not everybody will take up pediatric ophthalmology with a lot of interest, but it's very interesting. And a lot of developments can be made according to imagination and according to your needs. Thank you very much for your time.